When we're discussing head injury, head trauma, most textbooks that I've worked with in academia start with the easiest stuff, and that is concussion. It's a term that a lot of us have heard, even those of us that are not studying health related fields. Concussion, sudden transient mechanical head injury, a disruption of neural activity, stretching of nerve fibers, but no breaking, no actual damage. Now, in concussions, by definition, these people will be confused immediately after. They perhaps can't quite recall everything that happened kind of in the moments just before the brain injury happened. A brief loss of consciousness is there. And then they can have other kind of related neurologic manifestations. Headache, maybe some systemic stuff. For example, nausea and vomiting. The interesting thing about concussions is how much more seriously they are taken now than they were, say, 40 or 50 years ago. So my father-in-law is an ex-hockey player, and if you get him into a room, he will tell you about playing professional hockey back in the days before there were helmets. And he will tell you about all of the concussions that he had and how they would, do one of these and get you back on the ice. Because if you were out knocked cold, you were a liability. So people didn't think about anything at all. I have to give a lot of credit to the National Football League for really bringing repeated head trauma, repeated concussions, and some of the long-term effects to the spotlight and really get the public talking about a thing called post-concussion syndrome. A single concussion may not look as if it has clinical long-term consequences, but concussion after concussion after concussion after concussion can produce things called post-concussion syndrome. A little bit more serious than a concussion are contusions and lacerations that really just vary slightly based on their definition and actual location. So contusions, scattered areas of bleeding on the surface of the brain. Lacerations can technically be a little bit deeper because it involves the brain's layers, so get a little bit deeper into the brain. Both involve bleeding. Both may be relatively minor or can be major things that actually require surgical evacuation of blood to correct. Here you have some examples of common terms as they relate to common skull fractures. I will go in order of least severe to most severe. Least severe, number one, the linear fracture. As the picture shows, literally just a line. Go up a notch on the level of severity and you have comminuted fractures, which are by definition multiple linear fractures connected together. What makes them a little bit more severe is that by connecting, they can create sections of skull that are no longer stable in place. One rung higher on the ladder of severity, the depressed fracture, where pieces of skull are pushing inward toward brain tissue. Most severe of all is the compound fracture, where there is actually open communication to either the meninges or brain itself. In the setting of neurotrauma, Not everything related to the skull can easily be seen, even though there was perhaps a traumatic incident. For example, in, say, a car accident, there can be injury to the brain inside without necessarily producing a skull fracture. So think about a car accident where someone hits their head on the steering wheel and then hits their head back, maybe on the back of the seat, quite hard. And that motion type injury, where there's a flexion injury and then an extension injury, is referred to as the coup counter coup style of injury. If there is worry of some trauma to the base of the skull base, either the anterior, middle, or posterior fossa, one of the clinical signs you can look for, if this is not obvious, or if you're assessing someone right away and then trying to figure out where to send them first, if there is bleeding within the brain bases, in these, say, the anterior fossa, you may get ecchymosis around the eye. Raccoon eyes is what this is called. The middle fossa, if there is injury that includes bleeding there, may produce bleeding into the soft tissue back behind the ears, and this is called battle sign. One of the other things to always concern yourself with when it comes to neurologic trauma, this includes head trauma, very high spinal cord trauma, if there is something called diffuse axonal injury, popular clinical term, you can get very, very pronounced loss of cognitive function. That may include, for a time, clinical posturing based on the areas of the brain that are involved. There's two common postures that probably would be worthwhile adding into your vocabulary: decorticate and decerebate. For right now, we're just going to define them. Decorticate involves the unconscious person bringing the arms up to the core of the body. Decerebate, arms out and away. Intracranial bleeding can be a serious consequence of neurologic trauma. When you're starting to learn about intracranial bleeding, the most important thing I can tell you to do is to look at the terms, and they should tell you exactly where the bleed occurred. And they're usually relative to the meninges. So remembering our dura mater, our arachnoid, and our pia mater are very important here. Your three most common intracranial sites for bleeding are in the epidural space, the subdural space, and the subarachnoid space. As you can imagine, the clinical presentation of these hematomas, or collections of blood within the intracranial cavity, is hugely variable based on where the bleed occurred. However, a large enough bleed in the right spot can produce mass effect, just like a brain tumor. Mass effect can cause increased intracranial pressure. Increased intracranial pressure can push the brain in many different directions, including down. This could potentially be a clinical case where Cushing's triad may be assessed for by the nurse. A very serious consequence of neurologic trauma includes brain death. And brain death is defined by three things clinically: coma or unresponsiveness, absence of brainstem reflexes, and apnea, which is a lack of breathing. In that setting, a patient may be on a ventilator and have ventilatory support, but they're not able to breathe on their own. Brainstem reflexes involve doing clinical tests to look at these. For example, a pupil and the loss of pupillary reflex in response to light, or lightly brushing the cornea with a cotton swab to test for blink. These are examples of common clinical tests to look for brainstem reflexes. So that's a little bit on neurologic trauma as it pertains to the head. Now what do you say we go a little further down? Man, here is a scary one. Especially for somebody who has, say, vertebrae up here, spinal cord injuries. Now, let's just start with some basic terms. Injury, flexion injury, hyperextension injury, compression and flexion rotation. All different ways to damage or injure the spinal cord. So these are terms that you need to add into your vocabulary because they describe the mechanism by which the spinal cord was injured. And that's the first thing you got to know. What was the mechanism of injury? The next thing, and probably the most obvious, is the level. Where along the spinal cord did the injury take place? The third thing, and the one that's probably just as important here, is the completeness or degree of injury. A lot of people, when they're first learning about spinal cord injuries, think, woo, spinal cord injury, paraplegic, quadriplegic. Actually, tetraplegic is the term now. There are incomplete spinal cord injuries, and I'll touch on them in just a second. The other thing you got to consider when it comes to spinal cord injury is this idea of the primary injury and secondary injury. The primary injury is that mechanical force, that mechanism of action that we just talked about, a flexion injury, hyperextension injury. But in addition to that primary injury, there's going to be a secondary inflammatory response on the spinal cord that can itself be injurious to the spinal cord. Matter of fact, one of the reasons that people do not recover from spinal cord injury is that the inflammatory process that occurs after the injury actually inhibits meaningful nerve regrowth and healing. So if you go to work with spinal cord injury patients, one of the first things you're going to notice is, wow, people had injuries at C5, at T6, at L1. Why aren't they showing kind of this complete loss of function from that level of injury? And here's the thing. Sometimes injuries don't produce complete transection of the spinal cord. Matter of fact, based on the mechanism of injury and where the inflammatory process is centered, you can get incomplete lesions of the spinal cord. And here's your main three: central cord syndrome, anterior cord syndrome, and Brown-Séquard. Everybody always goes, oh man, do I have to memorize exactly these clinical manifestations? The main thing here is to know that in these syndromes, you have incomplete transection of the cord. Therefore, some function of the cord is maintained. That's the main thing I want to get across. If you go work in neurology, you'll have these down pat. What incomplete cord transections typically amounts to is an uneven distribution on one side or the other, or top of the body and the bottom of the body, with regard to thermoregulation, motor control, and sensory ability. These are the three most common, but know that even these three can have variable clinical manifestations in the people who have these incomplete injuries. All right, so here's the hard part. You basically got to know every possible level of injury and the clinical manifestations that would be present for every single one. Let's just talk about this in general terms, all right? This is for the introductory student. So a high-level injury up in the cervical spine, the main thing we're going to be worried about clinically is the effects on the diaphragm and breathing musculature and the coordination of good breathing effort. So the phrenic plexus, kind of pictured here, comes out of the spinal canal C3 through C5. So injuries at that level can produce then incomplete diaphragmatic innervation. Whenever that happens, clinically, you're thinking in your brain, okay, if the diaphragm can't do its job the way it used to, we could have some respiratory compromise, we could have problems with regard to gas exchange for these people. Lesions at C8 or higher will produce what is popularly called quadriplegia, but is trending toward the newer term tetraplegia. quadriplegia, and that means loss of motor ability in all four limbs. Injuries in the T-spine are variable in terms of their clinical manifestations, and you could probably guess that because it's kind of a wide range of the spine. The thing that I like to point out to students new to spinal cord injury is that T-spine injuries can produce clinical states whereby the autonomic nervous system goes out of balance, and we're going to cover that in just a second. Now, lumbar and sacral spinal injuries may not be as clinically serious as injuries higher up, but that doesn't mean that they're completely without clinical consequences as well. In most of these patients, some meaningful leg strength will result. However, there could be changes related to pain, neuropathic pain, and bowel and bladder innervation challenges as well. One clinical term to look up is cauda equina syndrome, injury at a level below even the conus medullaris in the spinal canal, a syndrome that produces pain and some bowel and bladder issues in those folks that have it. Here we've got three clinical phenomena: spinal shock, neurogenic shock, autonomic dysreflexia. We're going to compare and contrast between these three, and that's why they appear together. The first thing is comparing between spinal shock and neurogenic shock. And I put these two together because I've seen a lot of people switch the terms or assume they are interchangeable clinically, but they are not. Let's focus on spinal shock first. First of all, lesson number one, spinal shock is actually a misnomer. Shock, true clinical shock, involves hypotension and reduced tissue perfusion. Spinal shock is not true shock. So spinal shock is thought to be related to that kind of post-injury inflammatory response. It's relatively common, and look at the clinical manifestations here. Reduced reflexes, lack of sensation, flaccid paralysis. And the interesting thing about spinal shock is that it can mask what are actually the long-term permanent effects of the person's spinal cord injury as the spinal shock clinical manifestations start to wane. Neurogenic shock, by contrast, is true shock. In neurogenic shock, I like to think of it as a parasympathetic nervous system that goes unchecked or unbalanced by an appropriate sympathetic response. Remember from A&P, your autonomic nervous system contains parasympathetic and sympathetic ganglia, and those two sit in a balance to keep your heart rate doing what it's supposed to be doing, keep your blood pressure doing what it's supposed to be doing. If you got too much of one and not enough of the other, bad things could happen. So neurogenic shock is a clinical scenario where there's too much parasympathetic activity, and because of that you get clinical manifestations such as hypotension and bradycardia. Too much parasympathetic activity. Now, the opposite of that, autonomic dysreflexia. Instead of too much parasympathetic activity, we've got too much sympathetic activity without a corresponding balancing parasympathetic response. In autonomic dysreflexia, instead of hypotension and bradycardia, there is severe hypertension. The most common cause of autonomic dysreflexia is a distended bowel or a distended bladder. This is important to note clinically because when you're working with these patients who many times may have bowel and bladder innervation issues, something as seemingly small as, missing catheterization, a clamped Foley, a constipated patient, can have very serious clinical consequences and be that springboard that leads to something clinically such as autonomic dysreflexia. T6 is an important level to note because it's that area or higher where the potential exists for a disconnection or an imbalance between the two branches of the autonomic nervous system, parasympathetic and sympathetic. Therefore, at this level or higher, as a clinician, we are worried about and monitoring for signs that are indicative of neurogenic shock or autonomic dysreflexia.